We are pleased to continue our series with the University of Chicago Medicine, which the Orthopaedic Center at the University of Chicago, and we have another one of their great physicians in. He is an orthopedic surgeon, and he is Dr. Leland. Dr. Leland is an orthopedic surgeon with sports medicine. He provides expert care for adults and children with injuries of the bones, joints, and muscles. And of course, a lot of people will certainly be wondering what he can do to prevent these sort of things.
Well, good afternoon, and thank you very much for having me.
Listen, Doctor, it's great to have you here. Thank you so much. We were having a great conversation before the show started. I told him I want him to be, well, let me say this. He's a team physician for Concordia College in numerous local high schools, and has worked with the Chicago Blackhawks. I told him we need him at the Chicago Bears.
Yeah.
Right. I bet you can tell. I'll get your cell number and said, tell him to get off the field. Tell him to Doc, please.
Well, yeah, as we were talking earlier, it's very multifactorial. There are a lot of things that go into whether you keep someone in their position or pull them out, and whether it be the coach or the orthopedic surgeon, it can be a very difficult decision to make.
Yeah, right. But what got me here, and you being involved with all of these people, particularly professionals like the Blackhawks, for somebody in the teammates to say he's got a lot of courage, this is great, he's standing in there, that doesn't help the team win.
Yeah. I mean, I was listening in when you guys were talking just earlier about that same point.
Right.
I guess all you can ask from an athlete is to give it their all, do absolutely the best they can. Mm-hmm. And as you were saying, it goes beyond the athlete, and it's the coaching, and they really needs to make that specific decision, and it is a hard one. It is a really hard one. I mean, if they had won the game, we'd all be saying, wow, such a great decision to keep him in, because look, we won. But lost by 2, so everyone's kind of looking from the other direction. So it's hard.
Your position, for instance, with because we're talking professional sports as different from Concordia College, I'm sure, Dr. Leland. But what do you? The way we understand it is, now you as a team physician, you actually have the last word, don't you? If the coach wants to keep a player in and you're saying no, he shouldn't be in, that's what you say goes.
Yes, and it's because our role taking care of teams is to basically keep an athlete from getting further injured or from injuring themselves. Right. So as the physician on the field, you basically have to make the decision, it's not safe for this player to play. And the coach may beg you. And, in high school and college athletics, the family may beg you, and the player will beg you, and everyone begs you, please put him back in. We need him for this game. Right. But if the physician
feels...
Don't
forget
the parent. The parents.
Yeah, right.
Absolutely. The parents, the athlete, and the coach. And all the other fans on the sidelines will be begging you. Sure. But if the player's going to do more damage if they go back in, or they stand a significant risk of doing more damage, it's really up to the surgeon, up to the team doctor to basically keep them out.
The Blackhawks,
But one of the things actually that I get most frequently from patients is a lot of people feel that they have to be a professional athlete or they have to be a starting running back in order to come in to see me. And the truth is, nothing could be further from that. While we absolutely do deal with professional athletics and college, high school, all the way down to Pee Wee soccer, we basically are in the business of keeping people in the sport of life. So, no matter what your activity level, if you have joint-related pains, such as injuries to the knee or injuries to the shoulder, I would say 98% of the patients that I see are regular people that they just want to be able to either play their club sports or play basketball with their friends, play golf, tennis, or even just walk with their friends. And unfortunately, pain is keeping them from being able to do that. So they come in to see me, and that's when I can figure out what's going on with their problem and how we can make them better.
That's just great, what you folks are able to do. One of the things that you specialize in, Dr. Leland, is and we hear a lot about, is ACL injuries.
Yes, we hear a lot about it over the last year and a half.
Absolutely,
for sure.
Absolutely. Tell us what that is and what does it do?
Absolutely. So the ACL is one of 4 ligaments in the knee. It's basically in the center of the knee, and it acts to control rotational stability. So if an athlete or any person wants to cut or pivot on their knee, their ACL is what basically keeps their bone in place and prevents their knee from sliding out of place. So while after an ACL injury, injury, once things calm down and your knee kind of calms down from the initial trauma, you can walk, you can go up and down stairs, you can even jog without an ACL. But as soon as you try and cut or pivot on that knee, the knee will slide out of place, it'll swell up and be painful.
Now, that's a great explanation because that makes the distinction. A lot of people, as you know, as you said, we've heard a lot about it, Dr. Leland, and you're right, because of Derrick Rose.
Yes.
But a lot of people were sort of criticizing him, and particularly when Adrian Peterson, who had the same problem, came back as a running back and broke all kinds of records.
Yes,
but
absolutely.
There's a distinction there, isn't there?
Well,
And
you know, first of all, every injury is different. To say that just because the two athletes tore their ACL, well, they must have the same recovery and be back in the same period of time, it's different. The injuries were very likely similar injuries in the fact that they both tore their ACLs. But my question would be, what else did they do? Did they also sprain their MCL? Did they tear their meniscus? Did they do cartilage damage? Because those things that aren't necessarily talked about in the news can make a big difference in terms of when someone can get back. Another thing that really contributes to it is what position you play or what sport you play. For Adrian Peterson as a running back, obviously, a majority of his activities are going to be in line, basically in a straight line, rushing right up the field. Now, he's got big, heavy guys falling on him. He's got to move out of the way, so I completely understand that. But in Derrick's case, he really does a lot of pivoting.
Right.
Basically, every movement he makes is a pivoting motion. So his knee's going to see a lot, the ACL is going to see a lot of forces as soon as he gets back. You know, I tip my hat to both of them for the athleticism they have and for the fact that they can get back and play professional sports again after an injury that these days is almost looked at as minor, but it's not a minor injury, and it takes a long time to recover and return to their level of activity.
You're absolutely right. It's gotten so much attention, Doctor, and we're just so pleased that you're here to make us understand this. But how does it occur? Because, you know, they've shown where Derrick Rose went down. It didn't look like he did anything different than any other move. So
yeah, that's a great question. I love talking about that. So if you watch the video very carefully, Derrick is basically driving down the lane and he's right in the center, and he stops. He just does basically a jump stop where he stops and then jumps up in the air. But a split second before he jumps in the air, if you watch, and I think it's his right knee, if you watch his right knee, it goes into what we call a valgus position, where basically the knee is closer to the other leg than the ankle and the hip. And basically that knee kind of bends in, and it's actually it's the most common way of tearing your ACL. It's called a non-contact pivoting injury, where he doesn't hit anyone or no one hits him. He basically just tries to stop. But it's the very end of the game. I'm sure his muscles are probably weak, and his muscles kind of just fatigued at that point. And instead of being able to keep his knee rigid, his muscles fatigued, his knee went into that abnormal position, he ruptured his ACL, and then as he jumps in the air, he already ruptured his ACL, so he just tries to dish the ball off the minute he goes up in the air. So the instant he ruptured it is when he did the jump stop before jumping up into the air.
wow. So therefore, if it had not been Dr. Leland, if it hadn't been in the fatigued muscle, he could have done that very same thing with no injury.
Oh, I'm sure he's made that exact same motion hundreds of thousands of times over his career as a basketball player. It's just that one time his muscles just didn't do it.
So you know what the next question is: how do you prevent that? There's no way you can foresee it, is there?
Well, that's a very good question as well, and there is a lot of research going into that currently. We're working on research projects on how to prevent ACL reconstructions at the University of Chicago right now. I'm working with the physical therapy department to work on some exercises. Basically, there's a lot of different ways and a lot of different thoughts in terms of how to prevent ACL injuries. The main one is making sure your muscles are as strong as possible. When people come back from an injury, whether it be a neck injury or an ankle on the other side or a wrist, if they haven't been training and haven't been working and their muscles are weaker, they're a much higher likelihood of rupturing their ACL. There are also certain jumping mechanics. Women, for example, women basketball players are 2 to 4 times more likely than male basketball players to rupture their ACL. And one of the reasons why we believe that could be the case is because when women come down from a jump, they tend to land with their knees together. So all my female athletes, I tell them to, quote, land like a man. Basically, you want to come down from a jump with your knees shoulder width apart and equal so that your hips, your knees are directly between your hips and your ankles. And that position is protecting for the knee, and it'll protect that knee from going into that valgus position where the knee is pointing in the way it was when Derrick tore his ACL.
Does it help at all, Dr. Leland, to have some support? tape, whatever. Does that do anything?
There's been a lot of studies in terms of whether braces, for
right.
example, can prevent ACL tears, and unfortunately they can't.
Yeah.
They are sometimes used after surgery.
It's strictly inside.
I'm sorry?
Yeah, it's inside.
It's really, well, it's the muscles and things.
Right, yeah.
Bracing outside the knee is not really going to
Not gonna-
prevent an
okay.
ACL tear.
Wow, that's something. So what are Dr. Leland, what are treatment options?
So
Once
treatment
this
options.
happens, right.
Yeah, absolutely. It really depends on the level of activity. I see a lot of patients that may be in their 50s or 60s or 70s, and maybe they tore their ACL slipping on ice as the weather gets a little cold like it is today, or some other non-sports related injury. And a lot of times, if they're not competitive athletes, or if I ask them, well, do you play any cutting and pivoting sports, and they laugh at me because it's been quite a few years since they've played any cutting or pivoting sports, those patients can sometimes do very well without surgery. What I would do with those patients is send them to physical therapy, have them work on strengthening up their muscles again, and usually they'll be okay. And
really?
sometimes they may need an ACL reconstruction down the road, but most of the time they'll be okay.
So the muscle can.
Well, if you're not really doing very much pivoting, then you're not using your ACL all that much.
Okay.
And if you're not using your ACL, then if it's torn, you would do just fine. One of the things that I tend to use with my patients is if they come in and they describe a story where they tore their ACL and they tore their ACL playing sports, I would say just about 100% of those people are going to need to have their ACL reconstructed to get back to that sport. A majority of people that play hard enough to tear their ACL are not going to want to just give up sports and not play anymore. So that's really the population that's going to need to have the reconstruction so that they can get back to playing.
What is ACL reconstruction, Dr. Leland?
So an ACL, basically the ACL is, as I said, a ligament right in the center of the knee, and it's got a blood vessel that runs right up the center of it. When you tear your ACL, you tear that blood vessel, and as a result, there's really very little healing that occurs. There are some case reports where things can heal, but typically once it's torn, it's torn. So in that case, you can't just put stitches and allow the ACL to heal up. You actually have to put tissue in its place. That's why I don't call it an ACL repair. I call it an ACL reconstruction, because we're essentially trimming out the torn ACL tissue and putting new tissue in its place that will heal into the bone and function as a new ACL.
Where does this new tissue come from?
Basically, these are great questions. These are great questions. The ACL tissue, the tissue that you can use to become an ACL, you have two main options. You can either take it from your own body or have it come from someone who died, which we call cadaveric tissue.
Okay.
From your own body, the two main grafts that are most frequently used are hamstrings or bone tendon bone, which is basically a little piece of your kneecap, some patellar tendon, and then a little piece of bone below that. Another option is quadriceps tendon, but I would say the most common are probably hamstrings and bone patellar tendon bone.
So, and we hear about organ transplants and so forth. I know this isn't the same thing, Dr. Leland, but this isn't any situation where the body can reject.
Yes, you're right. You're right.
Yeah.
There's basically no rejection, but it is tissue transplanted from someone who died.
Yeah, right.
The difference is with organ transplants, you have living cells. If I were to get a liver as an organ transplant, they would have to have living cells in that organ. Otherwise, it wouldn't function as a liver for me. If all the cells were killed, then the liver would be no use. When we do an ACL reconstruction, the tissue that we take is just the structural tissue. We call it collagen, and it's basically just structural tissue that basically has very good resistance properties and works well as an ACL. But the tissue is thoroughly cleaned, very, very thoroughly. First, all of the cadavers are tested to make sure they don't have any diseases and things like that. But then it's very thoroughly cleaned, and all of the cells are actually washed out of the graft. So because there's no living cells in the graft, there's nothing that the body can reject.
Wow, that is interesting. Now, what can your patient, after you've done all of this, with the reconstruction I'm speaking of,
Yes.
what can they expect after that relative to, their movement and so forth?
Absolutely. So after I actually did 2 ACL reconstructions this morning. So both patients are in knee braces to basically help stabilize their knee while they're recovering from surgery. They're going to be putting full weight on their knee starting tomorrow, walking around with a knee brace. So they're basically walking, usually get rid of crutches within a week or so. The brace will stay on for anywhere between 2 and 4 weeks, depending on the individual case. They'll get into physical therapy starting 2 weeks after surgery, and that'll continue 2 to 3 times a week for 3 months. At 3 months, they're going to start jogging. At 4 months, they'll start running. At 5 months, they'll start working on their cutting and pivoting drills. And then I say patients can get back to full sports once they are 6 months out from surgery, assuming equal strength in comparison to the other leg. And if there's one person that understands that, that's Derrick Rose. He understands it's not just like a clock. You just 6 months doesn't come up and ding, you're ready to play. You have to have full strength before you get back out in the field, or you're more likely to do it all over again, and no one wants to do that. So basically, it's 6 months, but you have to have full strength. So frequently, that'll take a couple extra months for the patients to have full strength before they get back to full sports.
Now, you mentioned, may have to do it all over again if you do it too soon. But
Yes.
since, Dr. Leland, since you really have, it's not like a bone fracture when the bone adheres, but you're still the same bone.
Yes.
And it may be weak in that point where you broke it. But here you're replacing.
Yes.
So
But it still has to heal into the bone. So the graft,
okay, I got
basically
you.
the way
Yeah.
we do ACL reconstructions is we drill tunnels in the bone, pass the graft through it, and then fix it on both places. And the fixation is very, very strong, but it's not strong enough to last someone's whole life. So if they basically try to cut and pivot or do something too soon and their muscles aren't ready for it, they can actually tear the graft out of the bone tunnel where
I
it's
got you.
trying to heal.
Okay, that makes sense. So were you Peterson's doctor?
I was not, but if I was, I wouldn't be able to tell you.
Oh, that's great. So people they can play sports again, obviously.
Absolutely.
Yeah.
The point of, actually, point of almost every surgery I do is to get people back to doing the activities that they want to do, whether it be ACL reconstruction or a knee scope for a meniscal tear or a rotator cuff repair in the shoulder. I'm trying to get people back to being able to do everything they want to do with the minimum amount of pain possible.
Well, you led me into something we wanted to talk about anyway, Dr. Leland. Rotator cuff.
Yes.
Cuff, rather. That's the shoulder situation.
Right.
Most people hear about it. They don't know what it is.
Yes. Good question.
Yeah.
So the rotator cuff is basically a group of 4 muscles that goes over top of the shoulder. A lot of people think that they can raise their arm because of the rotator cuff, but really it's the larger muscles such as the deltoid and other muscles in the shoulder that allows you to raise your arm. What the rotator cuff does is it essentially stabilizes the humeral head, or essentially the ball in the ball and socket joint of the shoulder. It keeps it still so that your larger muscles can basically take over and raise your arm. If you have a rotator cuff tear, especially a large rotator cuff tear, what will happen is your humeral head will be moving all around when your muscles try to raise your arm. So what you essentially get is a shrug, where you start shrugging your shoulder instead of actually being able to raise it.
Now, what brings this on?
Well,
we have a
rotator
lot
cuff
of
tear,
pictures, of course.
yeah, a rotator cuff tear could be caused by anything from a traumatic event. I have patients that maybe would be an altercation or slipped and fell, or even just trying to lift up something heavy with their arm fully extended, and they can tear their rotator cuff. Other people, it develops more slowly, where probably it's small tears that kind of slowly get bigger, and they don't recall one specific injury. All they know is that they're in a lot of pain, they have pain at night, and they're not able to use their shoulder very well.
What is the average? You do the shoulders in addition to the ACLs and so forth, but I presume you do a lot more ACL work. Is that correct?
I do both. I would say ACLs is probably
I'm just talking
my...
about for need.
Oh,
the
for
patients,
need.
yeah,
For
yeah.
need. Okay. It's pretty variable. I would say as active as the population is currently, you have a lot of young athletes that tear their ACLs. But then again, as active as the population is currently, you have a lot of older people that, maybe 50 years ago, they would have been happy with just sitting in a rocking chair at 65 years old. These days, at 65 years old, people want to participate in marathons, triathlons, golf, tennis. I mean, 65 is young. I have 80-year-old patients that are playing golf, skiing, doing a lot of activities. So people are
Which
not...
is great.
Oh, it's fantastic.
Yeah.
And that's why I love my job, because I'm helping them to be able to continue doing all the stuff they want to do. I mean, never give up. Basically, just keep fighting. If you're having pain, come in to see me, see if I can help you, and we'll get you back out on the field, whether it be a professional sports field or just back out in the street, walk with your friends.
Shoulder dislocation?
Yeah, so shoulder dislocations is another thing. I would say we see a lot of shoulder dislocations in the same population that we see the ACL tears.
I see. Okay.
Tends to typically be the younger, very active patients. Anyone can dislocate their shoulder, but tends to be more in the younger, active population. And the problem with that is that once you dislocate your shoulder, you're more likely to dislocate it again. So a lot of patients can actually get by without surgery, but some will need to have surgery in order to stabilize their shoulder so it doesn't keep dislocating.
I can tell you like your job.
I do. I love my job.
Yeah, I can tell just the way you just, your expression, and you give us such great information.
Oh, thank you.
I just think that's wonderful.
Thank you.
Just to make sure we don't, I want to make sure, Dr. Leland, you give a number where people can visit you, the UC hospitals.
Absolutely, yeah. So the best number for people to reach me is basically 773-834-3531. Once again, that's 773-834-3531. That's our scheduling line to reach the Department of Orthopedic Surgery at the University of Chicago. So if you have an orthopedic complaint, give us a call, and we'll get an appointment either for you to see me or one of my partners, and we will get you back on the road to doing all the stuff you want to do.
And that's what's great about what you're doing. Your whole idea is your response to the question, which most, I'm sure, people, will I ever be able to play the sport again? And
and the answer is we will do everything in our means to be able to get you there. There are certain circumstances where sometimes people need to maybe take a different approach of what they want to do. Someone with moderate to severe arthritis in their knees may not want to be a marathon runner, but man, they can swim, they can bike, they can do a lot of activities. So, and a lot of times we will allow people to get back to all that they want to do.
You're a great guest.
Well, thank you for having me. It's a pleasure being here.
Dr. Leland, thank you so much. 773-834-3531. Appreciate it. I know the Hawks are in good hands.
Yes.
Okay.
Thank you very much.
Thank you so much.
Thank you.